women of my country. I'm Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desire something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of Fogsi, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Sri Shakti, as it is well. It is a guiding us behind all forms of body creation, and it's only a woman who can actually create a new life. Hi, I'm Kareena Kapoor Khan, and I'm so happy to be here with you. It's only on video. Pregnancy is a beautiful experience, and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization. Sri Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth, and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air, and pesticide-free food. Hi, I'm Nishu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl who is nurtured and a safe environment. Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond Fogsi's commitment towards women's healthcare. Fogsi for all, always. Fogsi for all is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India. And Dhira, to stop violence against women. Fogsi for all, always will strive to make the girl Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman. Dr. Shanta Kumari with the team Fogsi for all, always, and Dhira to stop violence against women will empower student girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman. Swasth Mahila. Violence against women. I think it's a silent pandemic, and I'm so happy to be a part of this campaign. If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is the first point of contact for help. So I have started Dhira, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women. I completely support her vision and mission as President Fogsi, and also especially support her campaign, Dhira, Stop Violence Against Women. A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the President of Fogsi, declare my commitment towards women's health and safety.
Thanks, Vikas, for sharing. Vikas, you can stop sharing.
Okay. Madam, sharing to stop, okay?
Put yourself on mute, Vikas, please. There's a lot of background noise. Thank you, Vikas.
Can I ask what was the problem there, Vikas? Can you correct it? Because if you start sharing something, the CVs and all that, there was a lot of noise. विकास जी
मैम मेरे को सही आ रहा था
नहीं यहाँ पे बहुत ज्यादा नॉइज आ रहा था मे बी इट वाज
दोबारा तो नहीं होगा
वीडियो मे बी इट वाज रिलेटेड नाउ इट इज नॉट देयर ओके सो वेलकम डॉक्टर बसम sorry if you did not catch the time I'm sorry because I had told you 4 p.m. maybe
no I missed out on the first part of it. Yeah, the second part I remember. Thank you Shubha. Thank you.
Sorry Basam.
Pranams to Dr. Chandravati. Hello to Ritu. Dr. Jyoti, nice to see you after a long time. Dr. Shikha, Dr. Sangeeta.
Hi.
Greetings to all of you. Thank you.
So,
Please proceed. Yeah.
Dr. Shobha, we can't hear you.
Yeah, please proceed. Can you hear me now?
yes,
Yeah.
Yeah, ma'am, we can hear you.
Yeah.
So moving
You
forward.
need to keep the mic closer.
Yeah.
So PSI is privileged to collaborate with Foxi for almost 12 years and have focused on doing simple things at the last mile despite many priorities. We have started a series of webinars for the states of UP, Bihar and Jharkhand, and this webinar is second in this series. The theme for the first series was Newer Larks and Limiting Options, where our distinguished speakers talked about DMPA, Foxi Eye Care, etonorgestrel implant, medico-legal implications of sterilization, and clinical pearls. The theme for today's webinar is Oral Pills, Benefits Outweighs Risks, where the speakers would be talking about Foxi Eye Care, POPs for all situations, COCs, and non-hormonal pill. Now, I'll take the pleasure of welcoming Dr. Shobha Gudi, Chairperson, Family Welfare Committee, who has always been so inspiring and the driving force behind these webinars. Welcome, Dr. Shobha.
Yeah, thank you so much. Yeah.
Vikas, can you please share the CV, ma'am ka? Dr. Shobha, she is MD DNB, FICOG, Professor, Head, St. Philomena's Hospital, Bangalore, Postgraduate Teacher, Examiner, Chairperson, Family Welfare Committee, Foxi 1921, President, BSOG 1819, Assessor, GOI Project Lakshya, Board
I
Member.
think, please pardon me, I think that will be great. I think we can go on to the next. I would like Dr. Shanta Kumari's CV, please. It is my proud privilege and honor to represent Foxi on this series of webinar. It was a pleasure to collaborate with PSI, and I stand ever grateful to the Foxi office bearers, the president, Dr. Shanta Kumari, who has become an iconic figure in the past few months, a very rapid recognition for her work. And of course, I do not think that she needs an introduction to this august audience. Next, please. Thank you, Dr. Shanta, for encouraging the work of Family Welfare Committee, and Dr. Madhuri Patel, the Secretary General of Foxi. I think by now all Foxians are aware that here is a lady who has made a mark in the man's world, and also she is highly efficient. I think we should stop saying about the gender. We should start thinking about how wonderfully well she has taken over from Dr. Tank, which was a very daunting task, and she has proved herself beyond our expectation. Thank you, Madhuri. She has the best words to say always, but today she could not be here. Next, please. And of course, the beloved Vice President, Dr. Basam Mukherjee, rating very high on the scale of popularity. And I think he also doesn't need much introduction. He was my predecessor as the chair of Family Welfare Committee, but that was only the beginning. Very well decorated faculty, FIGO Regional Coordinator and Secretary IRC India East, Vice President of the Bengal Society now, and next he will be taking up as President, and he also features in other chapters as well. Now, let me first also, before I ask him to give his message, I welcome and board the audience of all the 4 wonderful societies. And before that, I place my salutations to Chandravati ma'am for being here. And I think her blessings have been very vital for me as a chairperson from the very beginning. And today I am very happy that 4 societies of UP have joined us. Aligarh, Mao, and Muzaffarnagar, and also I think Meerut. So Meerut. So thank you very much for being here, all the presidents and secretaries and the members, the valued members of UP, because you will be the soldiers on the forefront. If at all we have given you any useful messages, you will be the one to implement. Dr. Basap, can I now ask you to speak a few words before we proceed? Thank you.
Thank you, Shobha. It's a pleasure being here. It's a pleasure connecting with PSI and all our own old friends. And as you said, that this association with PSI has been there for a long time. 12 years is a little more than 12 years. I think it's now in the 13th year. In between, there was some disconnections. In between, we did not connect. But overall, it has been a very close association amidst the different organizations that Foxy has dealt with. And this series of academic programs is something which we have started, and I'm sure that all the attendees will be able to clarify their doubts. Will leave here enriched with some more knowledge and some more determination and sensitization as far as family welfare and family planning is concerned. I think it's so important that we keep the discussion going, and I thank you, Dr. Shobha Ruby, from the Family Welfare Committee to lead it here and to bring the two organizations together. Dr. Ritu Joshi is here. My salutations to her. It's under her leadership that we started the association with PSI. I was fortunate to work very closely with Dr. Ritu, and she's the one who led us with PSI in the very initial years of the partnership. Thank you for being here. Madam Chandravati, Madam, thank you for being here. It's a pleasure always for you being here. Ritu, thank you for guiding the way and leading us forward. And it's all we are following your footsteps to be very, very, very clear, very correct, because you're the one who led it. And then we built up the association. Jyoti, Shikha became all very close to us over the last few of many years. Thank you. Thank you very much.
May I now have the pleasure of introducing our dear senior and veteran Dr. Chandravati. Can I have the CV, please, as guest of honor?
Can't hear you. Please keep your mic.
Yeah. It is now my privilege to introduce Dr. Chandravati. Again, introducing her with one page slide is like showing the lamp to the sun. But nevertheless, it is important to bring in few facts.
Stop
Yeah.
every time you have been introducing everybody knows.
मैडम आपका slide तो आने
बहुत
दीजिए.
बड़े हो चुके हैं, बहुत सीनियर हो गए हैं, सब जानते हैं, बच्चे लोग सब पहचानते हैं. And share ma'am CV. Yeah, I must just say that it is always a pleasure for any occasion when Shobha calls me, and this time Shikha was also there to invite me. And I must say that family planning is something which is like a half part of me. Rest of the gynecology is half. So I have been a person who has half heart filled with concern for family planning. And I always used to feel when I was young and working as lecturer and reader that probably by doing tumectomy, I would be able to cover all the population and do justice to my country. But then I was wrong. We didn't go into the right way. We never thought of spacing methods. We never thought of other ways of improving the fertility program. And I'm very happy, Shobha, that you initially Ritu was working so hard and you have taken over, and you was gone ahead for working so hard on this family planning committee and as a chairperson. And PSI has been working hard so every time, and to have collaboration with them. And I'm very thankful that you've chosen 4 important societies of UP and gradually taking many societies from UP and Jharkhand. And it is important that these societies join and they know something what you are going to discuss today. And I welcome all those office bearers of those 4 societies, and I thank them that they have collaborated with you all. I'm very happy to have 2 experts like both the Jyotis, and
important people. Jyoti Bajpayee is in this field for ages. Though she is my, student, but I know she has gone head above us all and has been working so hard in this field. And Jyoti Sachdeva from the Family Planning Directorate. So I'm sure these two experts are going to do justice to their presence there. And you have wonderful chosen the speakers for today's program, like Ritu, Basib, Anahata, and Dr. Riju. And I'm sure they are going to really bring out the subject very well and going to solve the inquiries from people who have joined from the participants. I wish good luck to this attempt of this webinar, and I'm sure all your webinars are going to do wonders in the coming future. Thank you very much for having me. Thank you.
Madam, thank you. Thank you so much. Thank you so much. But your life is an inspiration for all of us. Your work, body of work is really such a huge message to all of us that selflessness in private practice can be learned from you. I think you stand very tall for Foxians as an example to follow. And we are grateful that you are always there to bless us, because that is also, a rare thing, that somebody is so affectionate and so very giving when it comes to blessings. Thank you so much, ma'am, for being here. Thank you. I think now, Sangeeta, you should take forward.
Yes.
You should introduce Dr. Shikha now.
So thank you, Dr. Shobha. Your able guidance, stewardship, and vision has always encouraged us. And we always look forward to working with you. And now I would like to bring on board Dr. Shikha Srivastava, convener from PSI. Vikas, please share ma'am's CV. Dr. Shikha Srivastava, she is a consultant in PSI, chairperson Family Welfare Committee, Lucknow Obs and Gynae Society, obstetrician and gynecologist with over 28 years of clinical experience based at Lucknow, worked as senior advisor technical services.
You can keep
PSI.
short. No problem.
In PSI, provides high quality clinical inputs in the areas of health, family planning, medical abortion, post-abortion, and cervical cancer prevention. She led in development of Foxy GCPR for cervical cancer prevention, and she's passionate about sexual and reproductive health. Welcome, ma'am, and good evening, ma'am.
Thank you, Sangeeta. On behalf of organizing committee from PSI, Foxy, and all 4 district societies, I extend a warm welcome to all of you in this second module of webinar series on accelerating quality family planning services under Sankalp program. And we are going to learn updates on oral pills today. Benefit outweighs the risk. I just want to introduce something about PSI, that PSI India has positively impacted lives of millions of population in India through different programs spread across various states. Its technical and operational capabilities have attracted government, national and international philanthropic agencies and private players to collaborate as technical support partner on the issues around maternal and child health, urban health and family planning, sanitation and hygiene. Many of the previous speakers have introduced about the PSI and Foxy partnership. I just want to add few information that I'm very happy to see that all the founders are there. It was started on the leadership of Dr. Jyoti Bajpayee, who was Global Medical Director at that time, and Foxy President Dr. C.N. Purandare, and Secretary General Dr. P.K. Shah, and Dr. Ritu Joshi was chairperson since inception, and Dr. Baseb has been involved since beginning. And we are fortunate to have all of you today. PSI India, under its the Challenge Initiative program, envisions a world where young people are empowered to live an optimal reproductive life for rapidly and sustainably scaling up proven urban health solutions using a new business unusual approach along with government. The government already had the family planning program since decades. Many of the NGOs are also working. Few indicators have improved, but still we have to do a lot more to reach our goals. And I want to highlight the role of the private sector is very, very important. TCI program works with Government of Uttar Pradesh, National Health Mission, private providers to increase the use of contraception among urban poor in 25 cities of UP. And as we all know that use of contraception contributes to reducing maternal mortality by reducing the number of births and thus the number of women exposed to risks. And providing quality family planning services is very important, which includes providing adequate counseling and follow-up care. PSI, in collaboration with Foxi and other district societies, will further conduct 2 to 3 more webinars to provide an holistic approach around the family planning methods and services, and that will follow. In the end, I would like to thank all of you, and especially Dr. Shobha Gudi, to take this initiative forward as a family chairperson of Family Welfare Committee. She has been really a very powerful guiding force in organizing these webinars. So now I am delighted to introduce 2 experts for today, Dr. Jyoti Vajpayee and Dr. Jyoti Sachdeva. Can I have Dr. Jyoti Vajpayee's CV, please? The words will be very less if I introduce Dr. Jyoti. She has been my mentor as well. Her present engagement is she is a national technical expert for family planning and maternal and child health, Ministry of Health in Government of India. She is an independent sexual and reproductive health consultant, and she is consultant for Center for Catalyzing Change, C3, consultant with Bill and Melinda Gates Foundation, and she is currently a board member of PSI. She has been the country lead for family planning, Bill and Melinda Gates Foundation, governing board member of UCSF. She has been global medical director for PSI and country director in Engender Health. So her experience and vision around the family planning is vast, and really the words will short if I start elaborating all. Welcome, Dr. Jyoti. And I would like to request you to say a few words for the cause. Dr. Jyoti, please.
Please unmute yourself. Dr. Jyoti, please
Unmute
yourself.
Yeah, can you hear me now?
Yes,
Yes.
ma'am, we can hear you.
Okay, great. So thank you, Shikha. Good evening, everyone. Such a pleasure to be here. Thank you, Dr. Shobha, for inviting me. And namaskar to Dr. Chandravati, who's my guru, and Basab and Ritu. Such a pleasure to be on this panel with you. I must congratulate PSI and Foxi for arranging this very important webinar. But I must also congratulate all the doctors, nurses, service providers, health workers, and NGOs working in UP for the great NFHS 5 results that have come in and shown very, very good data for the country in family planning and for UP. So many of you may have read this, but I just want to reiterate that all your hard work, everyone's hard work, is actually paying now, and it is showing. The country, India, has reached replacement fertility level. The TFR, the total fertility rate, which is an average of number of children a woman can bear in a life, has come down from 2.2 to 2, which is below replacement fertility level. Our goal is always 2.1. Hum do, hamare do bolte. So it is really, really very exciting. And UP and Bihar have shown tremendous progress in family planning, if I may say so. UP has come down, the TFR, the total fertility rate, has come down from 2.7 to 2.4. And this is very good achievement, 0.3% decrease in 5 years. So congratulations to all of you. The contraceptive prevalence rate has increased from 45% to 62%, which again is huge. Congratulations again. and the unmet need for family planning has reduced from 18% to 12.9%, which is 5% decline, which again is very, very good. So things are looking very good. The population explosion, etc., we are answering all those questions and queries. The success has been attributed not only to all your hard work, but to major policy changes. And I work very closely with the government, so I've read all the analysis, and I'm very proud to say that when Government of India increased the contraceptive method choice, this was one of the major successes for the NFHS 5 results. Introducing 3 new methods: injectables, POPs, and weekly pills, non-hormonal pills. So 2 of these methods are going to be discussed by the experts today. Just introducing, expanding the basket of choice, it has attributed to the success of NFHS 5, the survey results. The second is the Mission Parivar Vikas, which is, looking at customized strategies for customized districts. And I know in UP, there were many districts which were under MPV, Mau, Muzaffarnagar, and Aligarh were also there. And looking at low parity couples, young couples, newlyweds, focusing on them and shifting the paradigm from sterilization to spacing methods. So these have really attributed to the success, but the success is really because of the hard work of people working in UP, to our Foxy champions and to all of you. So with these congratulatory message, I would like to, again, welcome you to this fantastic webinar. I'm so excited that 2 new methods which the government has introduced in the last 2 years is going to be discussed. So thank you again, all of you, for joining in, and thank you, Foxy and PSI, for inviting.
Thank you, Dr. Jyoti, for your insightful explanation of our hard work, what we have done and what we have achieved with the data. Thank you so much. Now I would like to introduce Dr. Jyoti Sachdeva, who is a family planning expert and lot of experience in this area. So I am happy to introduce her. Please display her slide. Can it be on the, yes, thank you so much. So Dr. Jyoti is State Program Officer, Family Planning in Directorate of Family Welfare. Earlier, she has worked as postpartum in charge in MAMC and Lok Nayak Hospital, Pandit Madan Mohan Malviya Hospital, Nodal Officer for RCH, District Program Management Unit South District, Nodal Officer for RCH, NRHM and ASHA. She was Principal Health and Family Welfare Training Center, Directorate of Family Welfare, and she has special interest in reproductive health programs and safe abortion services. And her achievements include rollout of several family planning schemes, rollout of new contraceptives, including PPIUCD, injection, MPA, and Chaya, skill development under family planning and comprehensive abortion care, represent India in policy dialogue in SRHR at Ethiopia, and she is recipient of State Award in 2013. So I would request Dr. Jyoti to say a few words.
Sure, madam. Thank you so much for introducing me. And I also want to thank Dr. Shobha Gudi for making me part of these elite platforms and organized by societies other than Delhi. And in fact, Delhi featuring in other societies, including other resource persons also contributing. So I really am thankful. It's a learning exercise for us also. Madam Dr. Jyoti has given lots of figures and all, but I just want to say one thing about the family planning program, that it is a unique program. It is the oldest program. It is unique in the sense that it affects the indicators of other programs also. And besides introducing new methods, family planning program, Government of India has been in the lead for logistic management also. So this is LMIS is a very unique thing. So things have been made simpler for us with the introduction of newer contraceptives. We at least have choices for lactating mothers also, which we used to wonder what to do. If they did not want IUCD, then we were at loss. So we have been handheld, we have been supported by Government of India. We have also, our Prime Minister also said that, you know, it is everybody's responsibility. So, and we are working so hard towards improving the quality of services, making our clients happy, improving the continuation rates. And this program is also unique in the sense that we integrate with other sectors, other programs, especially HIV/AIDS. And so I really want everybody to, you know, be a mouth and hand for family planning program. And for that, we need to have good technical knowledge also, good counseling skills also. So all that will be covered today as far as centroman and other oral pills are concerned. One more thing I want to say, that Government of India has also given us a lot of rich resource material, manuals, and some of the people sitting here are part of the technical resource groups for Government of India. And besides that, they have also given us e-modules. So during COVID, we did say that family planning is essential service. And we did support the service providers and trainers by giving them e-modules. So ministry has given us e-modules, and madam has very rightly called this meeting webinar as acceleration webinar. So everybody is in a driving mode, but we don't have to put any brakes. We just have to keep accelerating. And I would request everybody to, you know, familiarize themselves with the e-modules. We already had PPTs, standard PPTs on these new methods, but now we have standard e-modules also. They should be optimally utilized. They should be, you know, percolated down to, because we have it in Hindi also, and Delhi is lucky that local language is included. So we have two folders, one in English, one in Hindi, and other states can develop their own in local language if they want. But otherwise, English ones are so simple and well explained, and they are beautiful resource material. And I would request, you know, right from faculty to other program trainers, to program officers, to service providers, stakeholders, ANMs also, to use these. And the Hindi ones are actually very simple for Asha also to understand. So with that request that we should put in everything into this program to achieve for our, you know, health of mothers and children. And now looking forward to listening to the experts.
Thank you so much. Thank you so much, Dr.
Hi, Jyoti.
Yeah.
Hello.
How are you?
Now? My senior.
And I am really proud of you.
Now I think we should proceed for the technical session. Sangeeta, please.
Thank you, but I must
Unmute yourself. Unmute yourself, yes.
No, I
Thank you.
Yeah. Thank you, Dr. Jyoti Sachdeva and Dr. Jyoti Bajpai. Wonderful, wonderful comments by both of you.
So now I'd like to welcome the chairpersons, Dr. Manju Gupta, President Muzaffarnagar Obs and Gynae Society. CV please, Vikas, CV please. Vikas, please share the CV. Welcome, ma'am. Dr. Manju Gupta, she is MBBS DGO from LRRM Medical College, consultant at Vasu Hospital, Muzaffarnagar, ex-secretary Muzaffarnagar Obs and Gynae Society, and at present she is president of OBGYN Society and member of UPCOG. Welcome, ma'am. Next, I'd like to welcome our next chairperson, Dr. Kusum Verma, President Mau Obs and Gynae Society. CV, please. Dr. Kusum Verma, she is Director, Ashish Nursing Home, founder member of Obs Gynae Society, President Obs Gynae Society, Mau, Chairperson AICOG Kolkata 208, AICOG Varanasi 212, Past President IMA Mau, ex-Vice President and President, UP Nursing Home Association, Mount. Welcome, ma'am. Welcome, Dr. Kusum. Next, I'd like to welcome Dr. Priyanka, Secretary, OBGYN Society, Meerut. Dr. Priyanka is MBBS MS, Diploma in Advanced Gynec Endoscopy from Germany. She is an obstetrician and an endoscopic surgeon at Newtoma Super Specialty Hospital, Meerut. At present, she is Secretary, Meerut Obs and Gynae Society, North Zone Coordinator for Spina Bifida Foundation, National Speaker, Pfizer India. She is an executive member of Safe Motherhood Committee, Foxy. She is champion of Vistrit Jeevan Dhara, which is an initiative of Safe Motherhood Committee. She has her field of interest as minimal access gynec surgeon. She has numerous publications to her.
If Priyanka doesn't mind, can we go on to the next?
Yeah.
If Priyanka doesn't mind, yeah. Priyanka, is it okay? Yeah. Next.
So
please.
next, moving on to welcome Dr. Namrata Bhardwaj. She is Secretary of Zen Gynae Society, Aligarh. She is a consultant at Bhardwaj Hospital and Advanced Laparoscopy Center. Ex-assistant professor, GN Medical College, Agra. She delivered Kamini Rao oration at AICOG, Calcutta, and had been a part of Foxy Adolescent Committee, co-organizing secretary of 19th UPCOG at Aligarh in 2007. Welcome, Dr. Namrata. So I'll request the chairpersons to take forward these scientific sessions. So requesting Dr. Manju Gupta to move forward and take ahead the scientific sessions. Has Dr. Manju Gupta joined?
Dr. Manju Gupta? I think without wasting time, we can ask the next chairperson.
We can ask the next chairperson to introduce Dr. Ritu.
Dr. Kusum, can you please take forward the scientific session?
Introduce Dr. Ritu Joshi.
Good evening, all of you. Am I audible to you?
Yes, yes, yes.
Yes, ma'am.
Good evening, all of you. It is my, I am really thankful to be part of this webinar. It's so encouraging. And kindly put the CV of Dr.
Ritu Joshi.
Please put the CV.
Vikas, share the CV of Dr. Ritu.
Dr. Ritu Joshi is senior consultant, Fortis Scott Hospital. She is Vice President, Foxy 2014. She is Chairperson, Family Welfare Committee, Foxy 2009-12. Faculty in various national and international conferences. She organized conferences and workshops in obstetrics and gynecology locally as well as on national level. She has contributed various chapters in books of obstetrics and gynecology. She is editor for books on contraception. She has presented many papers and posters in national and international conferences. Certification course in advanced in recurrent pregnancy loss therapy from American School for Continuing Medical Education. Now over to Dr. Ritu Joshi.
Should I start sharing my screen?
Yes, yes, ma'am.
Yes.
Can't do that. New share.
Vikas, can you share POP for all situations?
I think it'll be better if he does.
We'll do that.
Yes.
Madam, you stop sharing.
Stop sharing, please.
Okay, I'll stop sharing. Stop.
Vikas, share the presentation POP for all situations. Yeah,
Yes.
thank you.
Thank you.
A very good evening to everyone. I am seeing somewhere around 144 people who've joined as participants, and I hope we can deliver what we really want to do. There is something, as we are going to talk about the oral contraceptive pills, we are going to talk in terms of progesterone only pills for all situations. Next slide, please. We are well aware, has been already spoken by all the earlier members, that the need and role of contraception is very important, even in decreasing the maternal mortality. Now, we've had a very good revolution of contraceptive use, but still our unmet need for unwanted pregnancies is very globally still very high and a major health problem. Now, one of the important things of all the factors which really influence a woman's choice of contraceptive method is the effectiveness of the method, her personal preferences, and the potential of additional risks. So most important associated is the additional risk profile. Next slide. Whenever we have a woman who is in her postpartum period, we do advise her a few things before discharging her. One of them happens to be contraception. Next slide.
Hello.
And as far as the postpartum contraception is concerned, we find that for women who are breastfeeding, it's a major public health issue of importance. The contraceptive method chosen should not interfere with lactation, which is very, very important. And the contraception use may contribute to the improved birth outcomes by lengthening the intervals between the pregnancies. That means they should act like a long-acting contraceptive methods. Next slide. So it is important to prevent unintended pregnancies and short interval pregnancies. We find that the women are assumed to be protected from pregnancy for 4 weeks following a delivery. In a non-lactating woman, the first ovulation occurs between 45 to 94 days postpartum, and the earliest ovulation reported has been 25 days. And of course, the lactation periods, the period of postpartum infertility can extend at times till she is feeding the little one. Next slide. So these are all the times when we have to be very particular about it. And there are various factors which determine the choice of contraception in these women. Does she want a temporary or a permanent method? Is she feeding the baby? If she is a breastfeeding woman or a non-breastfeeding woman? And to the extent to which the informed consent prior to the delivery has been given to her during the antenatal period. Next slide, please. When do we initiate contraception in these postpartum women? We should, the COCs are contraindicated in the first 2 to 3 weeks because of the VTE. They're also not to be used in those women who are breastfeeding because it decreases the quality of the milk and the quantity of the milk. The menstruation and the ovulation can be unpredictable in most of these women, and the timing of contraception to be started becomes very, very important. So for a breastfeeding woman, she should start a birth control by 6 weeks. And for a non-breastfeeding who ovulates within 45 days, it should be started as early as possible. Next slide. What are the options available? The options available are non-hormonal. There could be progesterone-only hormonal methods as well as the other hormonal methods which are there. Next slide. So if we talk in terms, all this has already been proved by, has already been spoken by the ACOG and the WHO, that the women who are breastfeeding should not use oral contraceptive pills before 6 weeks postpartum. And also they should be concerns about their impact on the milk and the composition as well as the quality. Next slide. So we have these COCs with us, which are estrogen containing pills. What is actually the potential barrier to use them? Of course, we've spoken about the breastfeeding. The second important thing is this, that it has to be avoided in women who are already, who are estrogen sensitive. there are a lot of health risks attached to it, like thromboembolic diseases, it cannot be given, cardiovascular diseases, it cannot be given, diabetes, which has its complications, dyslipidemia, women who are smoking, who are obese. So what to do about all these women? Next slide. So we find that, as far as the WHO medical eligibility criteria shows us that the COC should not be used in all these women. Next slide. So what do we use? We are left with progesterone only contraceptives. And these progestins are synthetic progestrogens. They act on the progesterone receptor, and however, they have their own specific effects also, and used as medication in managing variety of conditions. They are used as contraception. They are used for HRT also. Next slide. And these pills contain very low doses of progestins. The oral progestins are mono preparations, were originally intended to be used during the breastfeeding, as the risk of this thing, VTE is very high in postpartum period, and as well as the estrogen production, we know, as we spoke earlier, reduces the breast milk quality as well as the composition of it. So we now term them as midi pills, as they contain very, very low doses. Next slide of the progesterone. Which ones are available to us, the progesterones? We have the progesterone only pills, we have the injectables, we have the implants, and we have the hormonal IUDs. Next slide. But as far as the progesterone only contraceptives, all those which were mentioned earlier are concerned, we find that the depot progesterones, they are associated with 3.6 fold increase of venous thrombosis. Then they can delay the return of the fertility. These are the concerns attached to them. The concerns with the implants and IUDs are menstrual disturbances, the headaches, the weight gains. At times when you're putting in an IUD, there could be perforation of the uterus. So these things are a major concern. Next slide. Next slide, please. So we now have the progesterone only pills, and they are classified into two groups, which are traditional progestins as well as the newer progestins. The traditional progestin, which we were using, all of us earlier, and we were very particular about starting it and hammering it into our women that please, please, please take it at the same time every day till you don't want to conceive. That was levonorgestrel. It was in a dose of 0.030 milligrams. A continuous administration was required. Then we had the newer ones, which is desogestrel, 0.075 milligrams. Again, a continuous administration is required without a pause in between. But now we have another new one, which is the drospirenone in a dosage of 4 milligrams. It is to be used as 24 days and with a pause of 4 days, and to be continued after the pill free. The next packet can be continued. I'll tell you in my next slides as to why this method is very helpful. If we compare all the progesterones which we spoke about earlier, the androgenic activity is associated with the adverse effects such as acne, hirsutism, and altered carbohydrate metabolism. The newer progestins have been developed to bind very specifically to the progesterone receptor. And also we should know that the drospirenone, which is derived from 17-alpha spironolactone, binds more selectively to the progesterone receptors and are likely to have less androgenic activity than the other ones, which are derived from the testosterone. Next slide. How do these progesterone-only pills act? For a traditional progesterone use, again, the combination of cervical mucus thickening is there, preventing this firm penetration because the cervical mucus thickening, and reduction in the endometrial receptivity. The newer progestins like desogestrel and drospirenone also inhibit ovulations. So we find that with these two newer progestrogens which are there, the ovulation rates are comparatively very less, which is around 1 to 2 and almost 0.8% in case of drospirenone, and as comparison to the levonorgestrel, which has almost 6 to 8%. Next slide. So the traditional only, which is levonorgestrel, has a low inhibitory capacity over ovulation, and the Pearl index of typical use is between 6 and 8. The daily use is very important of that at the same time within 24 hours, because it has only a strict 3-hour daily missed pill window. So these progestins act on the cervical mucus again, and it increases the risk of the method failure. Next, please. And if we compare the return of fertility as to what the progesterone only pills is, if we compare it, we find that it is comparable to any other method. Next slide, please. But there are a lot of adverse effects to the traditional progesterone only pills. It causes abnormal bleeding pattern. Rather, the discontinuation was almost up to 25% in most of the women because of the irregularity of the periods. Also, they can cause acne, they can cause hirsutism because of the androgenic activity. And it has been reported, like we had for IUCD also, the levonorgestrel has been causing a lot of ectopic pregnancies. Next slide, please. The second one is desogestrel, the POP. It is estrogen-free inhibition 97% of the cycles. Then it does not bind with the lipids and the carbohydrates. The metabolic side effects are very less. It alleviates the menstrual migraine. It reduces the pain in women with endometriosis. And its missed pill windows almost 12 hours. Next slide. Next slide. There are side effects as any other one, but today the newer one is drospirenone, a 4 milligram tablet. It is a novel synthetic progesterone. It is an analog of the aldosterone antagonist, and structurally it is different from the other progestins, as we can see in the diagram. Next slide. So how does it act? The drospirenone blocks the aldosterone activity and it prevents the salt and water retention. So there is no weight gain, the bloating is not there, the feet swelling is not there, and also may reduce the blood pressure. Next slide. So the drospirenone has a very effective, because of its progestin action, it is a very effective contraceptive method. Because of its anti-mineralocorticoid and anti-androgenic action, there is no weight gain, there's no bloating, as we spoke about earlier. And the anti-androgenic action, it does not increase the acne, and rather it may improve. So many times we use it even in our PCOS women who have more of acne on the face or on the body. Next slide. Who can use the drospirenone only pill? Nearly everyone. So this is, that POP can be used in all situations. Either they are breastfeeding of any age, which could include even the adolescents. There could be even women over 40 years who, have had a miscarriage or an abortion or an ectopic pregnancy, who do more than 35 cigarette smokings per day, regardless of their age, and even in women who have varicose veins or they have anemia. Next slide. So drospirenone is indicated for use by females of reproductive potential to prevent pregnancy. Next slide. Starting, how should one use it? Take one tablet on the first day of the cycle. Take subsequent tablets once daily at the same time each day for a total of 24 days. That is from day 1 to day 24, and from day 25 to day 28, it is a 4-day pill-free period. Begin each subsequent packet on the same day of the week as the first cycle. Next slide. And this improves the bleeding control and also maintains the estradiol. This is where, the 24 into 4 is very good because it improves the bleeding control. It also maintains the estradiol concentration at early follicular phase. That means that we are preventing the deficiency of estrogen. Otherwise, when you're taking continuous pills, we are actually preventing the release of the estrogen. Next slide. Now, in case, next slide, please. So in case if we have missed the pill, the important thing is that there is a 24-hour missed pill window, which is very good. So if you've missed one white pill, then you take the missed pill as soon as possible and continue taking one tablet a day until the packet finishes. And if you miss 2 or more, then you have to take it immediately, the pill, but you must have a backup method in the form of condom or a spermicidal or whatever. Next slide. So looking into the medical eligibility criteria, we find that the POPs are the safest ones. They either belong to category 1 or category 2, which are the safest for use. So I think the POPs, and especially this recent 4 milligrams of drospirenol, is a good pill which is now available, can be used in all situations which I mentioned earlier. Next slide. The contraindications to the POP is very less. They either use, which is with everyone, that a known or a suspected case of pregnancy, unexplained vaginal bleeding, or a breast cancer. But always remember that they do interfere with the absorption of the other drugs. So you should be very careful when you're using a concurrent drug. So anti-seizure drugs like phenytoin and all, antibiotics like rifampicin and ritonavir, or women who have undergone a bariatric surgery may have difficulty with absorption. There are very few contraindications to it. Next slide. So summarize the whole POP. We know that progesterone only pills is intended to be used for contraception in all situations, used in circumstances where estrogen containing COCs are contraindicated. The traditional POPs, the PI index we know is 6 to 8. There's a 3-hour missed pill window. There is a very high rate of irregularity in the bleeding. Similarly, it is again in the desogestrel also, the periods are irregular, and that is why they leave it. Discontinuation rate is very high, and it has a missed pill period of 12 hours, but drospirenol has a missed pill period of only 24 hours, and it is one of the safest POPs which can be used. Thank you, everyone. I hope I've been able to convey the use of POPs, how effective they are. I know that we had been using the levonorgestrel, and we all really had gone off using them because our patients used to discontinue, taking it at the same time, hammering it into them, having irregularity of the periods, which is not there with the newer progestins which have come up now.
So can I request Dr. Priyanka to address the new speaker, introduce the new speaker, Dr. Shobha?
Yeah, please.
I'm hardly new.
Good
Yeah.
evening.
Good evening.
Can I have a CV, please?
No, listen to
Ma'am,
me,
CV has
Priyanka.
been shared.
Yeah,
So
she
Yeah.
Dr.
has
Shobha,
shared it.
please.
So
Yeah.
Priyanka.
Good evening, ma'am. Let me have some words for you, ma'am. She needs no introduction. Whenever we talk of contraception in Foxy, we talk of Dr. Shobha Gudi, madam. She has been with us in Meerut twice. And ma'am, we had a very well validated lecture on IUCD as well. And it is a pleasure to listen from her today.
Thank you, Priyanka. Thank you so much. With that, I will share my screen and I will get going because I think I have a lot to learn, as I said, from the previous speaker, Ritu ma'am, because
Ma'am, you are not audible.
I have a lot to learn from Ritu ma'am, I
thank
was
you.
saying, because she finished in time, and also she gave all the messages in an unhurried way, but there was a lot of information. Thank you for making it so simple to understand, and I think it was a very comprehensive lecture, Ritu ma'am. Thank you so much. So now, yeah, thanks, ma'am. So now I think this is a concept which I have been speaking about from the very beginning when I took over. And this is something which I have a very firm conviction in my mind about this. But I feel that more and more Foxians should identify themselves with this, especially those who have their own maternity units. They must look towards establishing something known as an eye care clinic. Eye care stands for integrated contraceptive approach across reproductive age. And basically, the premise is that every woman who walks into our hospital or clinic or nursing home should be assessed for her unmet need, because there will be one many times, and then we need to address that unmet need in addition to the problem with which she has come. So as I go through my presentation, which will be a very brief one, you will come to know what exactly I mean. You must be wondering what the SDG logo is doing here. Well, SDG 3 is for good health and well-being, you all know, but we have for women's health SDG 3, 5 particularly, and SDG 17, and of course everything else as well. But these three relate most to women's health. And I feel that if we have integrated care inbuilt into our system, not only for contraception, but for other health parameters, I think that we will succeed better in attaining the sustainable development goal. So with that, I shall move on. Well, women should be educated and empowered. Hardly there is any doubt about it. Only then and only then will they seek out solutions for their own health. Otherwise, from kind of childhood to old age, they remain dedicated to the family, and they will be looking after the other family members' health, and their own health is not a priority. And that is how, they suffer. So when girls are educated, healthy, and can avoid child marriage, unintended pregnancies, infections like HIV, we all know that they can contribute fully to their society's battles against poverty and many more social evils, because a woman's force, a woman's wisdom, is a power in itself. So this is a very familiar, this should be a very familiar world map to all of you. Please kind of become tuned to this, familiar with this. What I am trying to say here is India's contraception prevalence rate is the light blue. We must become the dark blue. It is 50 to less than 70%. In order to achieve population stabilization by 2030 or even 2040, we need to become the dark blue, and that is more than 70% contraception acceptance rate. Dr. Jyoti Bajpayee very beautifully described the NFHS 5 results. It's so highly it was praised. I fully agree with her that we have made a lot of progress, but then the contraception prevalence rate from that, which I understood was around 65%. So we have still to cross the magic line, and it will happen if all of us put our efforts together to increase the contraception acceptance and continuation rate. Eye care is a very important tool. This is also showing, as you can see, that the private sector today caters to 30 to 40% of births, but contributes to very little to the family planning needs of women for the modern methods. So it is a little paradoxical, because modern methods are more with private sector than with the public sector, but the public sector has just pushed ahead with its family planning programs so wonderfully, with such a trajectory, such a force, that a lot of women in the who seek healthcare at public health are able to accept and continue contraception. That is not happening in the private sector. And so to say, as there is a change of health seeking behavior and more women now come to private sector, the onus is on us to see that they accept contraception better. Well, this is an older data, and it, as you see, that it does show a collective unmet need of 13 to 17%. We will not go, because this is all changed now. I must also change this slide. And as Jyoti said, it has decreased to 13%, and 9 to 13%, I would say, but then it should remain consistently below 10. Then only we are making very sound progress. Let us understand that reproductive wellness is a reality, just like health by WHO is defined as a state of complete physical, mental, social well-being, and not merely absence of disease. Similarly, reproductive health definition is also a positive one. That means it is not merely the absence of disease or disorders of the reproductive process, but it is a situation where couples are able to have responsible and satisfying and safe sex life, and they have the capability to reproduce and the freedom to decide if, when, and how often to do so. And implicit to this is the fact that we must provide them, and they should have access to safe, effective, affordable, and acceptable methods of for fertility regulation of their choice. No, this lecture may be going towards the public health. You must be feeling that I am talking too much of public health here. But please remember that reproductive health is intricately linked to reproductive rights. So if we think about reproductive rights as a public health matter, reproductive health as a clinical matter, both are intricately linked. Reproductive wellness is a reality. And we need to understand that, contraception is very vital. This is the spectrum of unmet need. All women who are not tubectomized or hysterectomized or menopausal have a need for contraception. You must understand that. And there is a large spectrum. That is the need. That is why we miss out on this. We miss out. We think that only women who have delivered needs to be told, or abortion need to be told. But there are a lot of women. They may be adolescent and sexually active. They may be, wanting to just put off the childbearing, and they are married or even unmarried women who are in intimate relationships. They may have currently be having an untimed pregnancy. They may be perimenopausal, not tubectomized. So there is a huge spectrum of unmet need, and to catch them, we need to have integrated care. So these are models of FQHC, quality healthcare clinics, where it was identified that integrated care will overcome the organizational barriers, the provider barriers, the community level barriers, and everything else can be overcome. And we will have increase in low income women being offered reproductive life planning, increased access to contraception, increased utilization, and reduced unintended pregnancy rates. So WHO has long understood the need of integrated service and has said that management and delivery of health services in an integrated way will ensure that clients receive a continuum of preventive and curative. See, it is a chain, a continuum of preventive and curative services according to their needs over time and across different levels of health system. So this is a systematic approach to care with better patient experience, improved health, lower cost, and requires strong communication and collaboration within an organization. In other words, it requires solid team effort. It is not only the obstetrician who can make this difference. So this is a wonderful model of family planning and HIV integration, and it has had huge success in South African sub-Saharan countries, and has brought down the incidence of maternal deaths and of HIV infection, and also unintended pregnancies and abortion rates. So this is the flow chart, which is showing that women 13 to 49 register for primary care visit. During the primary care, reproductive intention is systematically measured. Does the woman need to have a baby? Yes. Refer for counseling to OB-GYN, take the counseling for preconceptional care. No. Is she using an effective method? Yes. Discuss the currently used method, refill, continuation, complete the patient visit. Does she agree to use the method? Yes or no? Then you can go ahead. If she's not using an effective method, then you need to offer her the basket of choice, discuss all the methods, facilitate a choice, and that is how the gather approach comes in, and complete patient visit comes in when the prescription is written or the device is inserted or the injection is given, etc. The concept of integrated care for contraception means that several other people should talk contraception, should discuss contraception, should discuss family planning, reproductive planning, spacing, healthy spacing, the value of spacing, etc. So the pediatrician, the family physician, family and friends, obstetricians, midwives, dietitian, nurses, ashas and ANMs, everyone should discuss this and enable the woman to make a dignified choice of spacing her pregnancies. Remember that all sexually active women, they need accurate information that they are at risk for pregnancy, and they should be offered the options. Now, having an integrated care will also increase the male participation, and this has been proven across the world that such clinics where men are called in will bridge the gap between the male partner and the healthcare provider. Tools like this can be kept for the eye care clinic. This is the effectiveness chart, and you can see the arrow pointing upward from less effective to more effective. Very well recognized chart by WHO, by ACOG, and by USAID, and several other statutory organizations. And you can see that the highest level are the implants, IUDs, equally effective as the sterilization, and then come the hormonal methods along with the LAM, and so on and so forth. So this is a very useful chart, and on the right side is exactly the tip which will tell the client what is it in that method which will increase the efficacy of the method, how exactly to use it. Integrated approach will require structured contraception counseling using standardized protocols and aids. This is the key to provide the information about all the methods and quality care, initiation of contraception, and the follow-up visits. So counseling is important. Recommendation for LARC counseling, for example, establish the need, introduce the LARC, communicate the benefit of LARC, provide reassurance, address the concern, help with the decision making, confirm the choice, and schedule the placement of IUD. So these are the 6 key recommendations for method specific counseling once the LARC has been chosen from the basket of choice. What is the rationale behind implementation of integrated family planning? Every opportunity of contact is utilized, every opportunity of contact with the client or the patient, as she may be called. All women in reproductive age, sexually active, not tubectomized, hysterectomized, they need contraception counseling. It ensures women's autonomy, addresses poor male participation, assures accessibility, unmet needs are met, improves quality of care, better patient experience, improved outcome at lower cost. Yes. And the integration can happen at every level. Okay, adolescent, preconceptional, antenatal care. That means a girl coming in with any health problem, we can tell her, if she has come with a SRH problem related to her cycles, related to her infections, etc. We can always educate her about contraception. Of course, prescriptions cannot be given till they are 18 years of age, but counseling and information can be given. Preconceptional care, yes, antenatal care always should to be strengthened by integrating contraceptive counseling. We routinely do it during the second trimester of pregnancy. Postpartum care, of course, to be firmly ingrained with family planning. Comprehensive abortion care cannot be done without family planning. The opportunistic time is when the interval situation of visit. Okay, whenever she comes for screening for cancer, health check, menstrual problems, premenstrual tension, etc., etc. That is when we find out, is she keen on pregnancy, is she not tubectomized, and we can give her the method or offer her the method. The premenopausal woman coming in for other difficulties, please do not think that once they have menopausal symptoms they cannot become pregnant. They are at high risk because the gonadotrophins will be higher at that time and they will be playing havoc with the ovulation status. Integrating immunization with family planning, ICTC, PPTCT, and integrating RTI, STI clinics. So how much integration can happen in your setup? It is limitless. And besides this, clinic care can be integrated with community outreach programs, wherein you can, have telephonic messages and video consultations tagged in along with the initial visit. And then community service delivery points like Ashas going out in public health. Similarly, hospitals can reach out through their personals for door-to-door delivery. The service is the eye care clinic. It is a dedicated cubicle or clinic in the OPD floor of every private maternity service. Counselors trained in family planning should be there. It should be available. Room should be equipped with charts, models, samples, and take-home material like brochures and information leaflets. And nodal training centers ideally should be established for training of such counselors, making all FP related services free or nominal cost. Please remember, reduce the cost of family planning visits or counseling process, and that will go a long way. All right, so these are some examples of the different situations: the preconceptional, prenatal, interval situation, etc. So I don't think we can take this forward. One word about preconceptional care is that WHO has got an entire module, and a key part of the module is too early, unwanted, and rapidly successive pregnancies should be advised against during the preconceptional care. And these are some messages for adolescent population, how to prevent sexually transmitted diseases, and integrating contraception with STI prevention is a very useful thing to happen. This is an example of a woman with her baby walking into the registration area. She has come for immunizing the baby. They arrive, register. The mother takes the child for immunization. The vaccinator provides information, refers for family planning. He says, okay, I have given you the shot. Now you go to room number 4 and take the family planning advice. The mother says yes and goes here and takes the basket of choice, selects her method. The counselor, gives her adequate method specific counseling, and then she leaves with the method, or she declines. Well, I must say that this can happen, because remember why she came in? She came in to immunize. So she may not be all that open to this in the very first time. So she does not go just like that. She leaves with a brochure. She leaves with information about the family planning officer or the counselor who met, and she leaves with a contact number which she can reach out for more help for contraception. So that is important to put in place. Okay. And how effective are methods? We should tell them that LARC methods are useful, especially in the pandemic. LARC was found to be very, very useful because they could not have repeated clinic visits. So gynecologists have an opportunity to intervene in the life course of women consistently throughout, through preconception to pregnancy, through adolescence, through adulthood, through aging, and during the reproductive years. We play a very, very important role for the women's health. We all know that. So Mary Estelle said, the feminist of the 18th century, perhaps the first one: if all men are born free, how is it that all women are born slaves and they do not have any control over their reproductive patterns? So that is something that we need to change. These are other examples of integration. The span of life is too short to be trifled away in unconcerning and unprofitable matters, and you will all be believe me and agree with me that unintended pregnancy is hugely unprofitable and is a very, very miserable experience for the mother who chooses to abort her child. What we lack today is focus. Let us make a difference in our service provision. Let us have Foxi Eye Care. Thank you very much. That was my presentation. Thanks a lot. Thank you.
Thank you, ma'am. Thank you for the wonderful, comprehensive presentation. And now I think, Dr. Sangeeta, we can move over to the next session.
Yeah, please move on. Yeah.
Dr. Basab is here. We have already introduced Dr. Basab. He'll speak about COC, safety net of MEC. Dr. Basab, welcome, sir.
Hello. Thank you. Let's start sharing my screen. Thank you.
So we can see your screen. Yeah.
Thank you. So so COC is safety net of MET, or medical eligibility criteria. So over the next 12 to 15 minutes, we'll have some discussion of medical eligibility criteria in particular. Not just COCs, there are several other contraceptives which fall in this in the medical eligibility criteria, especially when there are medical diseases or some conditions that a woman has where you are in doubt whether you can to decide whether one particular contraception is suitable for her or not, is eligible, she is eligible for it. When you counsel her, whether you will be counseling on that particular method is something which is very important to know. So, usually the doubt comes when there are hormonal contraceptives, estrogen, progesterone, and when they have metabolic diseases like diabetes and hypertension. But there are several other instances where people are in doubt whether this can be given, whether this should be given, whether which exactly method is appropriate, and that is when medical eligibility criteria comes in. Attitude is said to be a little thing that makes a very big difference. And I think it is very important that when there is a medical problem, we should not have an attitude that, oh, nahi, medical disease hai, nahi de sakte. So that should not be the first thought which comes to our mind. We should be thinking that possibly let us see whether she is eligible or fit or not, and then decide on what are the options which we can give her, and what should be what are the options which can be given to her. As we know, for contraception and family planning, which we keep on stressing, that the decision is made by her and not us. So we should give her at least 2 or 3 options of the different things which are she's eligible, and then to bring it forward. This is an old slide from WHO 10 years ago, but I think it still highlights the fact that one of the primary preventions of maternal mortality is family planning. And if we could reduce, by the use of family planning, several unplanned and unwanted pregnancies, then we would be reducing a lot of more of maternal deaths. I think Dr. Jyoti initially stressed, and we were congratulating each other, that the maternal mortality rate of India has gradually come down over the years, and we have made remarkable progress. But there is still, we understand, more work to be done. And one of the ways in which we can increase the work, decrease maternal mortality, is increase the use of contraception and try to reduce the unmet need. So this was the 5th edition of medical eligibility criteria for contraceptive use, which came out in 2015. A lot of you would be familiar with this book and about how it was there. And this is the wheel, which at one point of time was quite popular, and still is in some areas, where it was distributed and we used to turn it around. We used to give our orders from the WHO head office in Delhi, and we used to get it on post, and then used to use it in our clinics. So this is something which used to be there in the past, but it's something which is important to understand, that at one go you could be finding out that what contraception is relevant for her in which particular case. So just revising the basic things of WHO medical eligibility criteria, which most of you would already know. So 1 and 2 are the categories in which use is generally allowed. There's no restriction on use in 1, and advantages outweigh theoretical or proven benefits in 2. 3 and 4 are one usually where you would hold on to the method, where 3, the risks outweigh the advantages, and 4 is absolutely a no-no. It presents an unacceptable risk. So with limited clinical judgment, which some people are assuming in a field setting, we could say, if it is 1 and 2, use it. If it is 3 and 4, do not use it. Just have a blanket rule and try to follow that. So this was how it looked. If you opened the folder, you remember it came in 3 folds. And this was how it looked. And then this was how it looked inside. And this was the WHO medical eligibility criteria. Inside were all the numbers, as you see. 4 is when it's a no-no. So you were seeing hypertension here, which was 4, ischemic heart disease, stroke. This was the 4 for the combined hormonal contraception. So these were the things in breast cancer, in active liver disease. This is where it was all there. And this was several points from where you could have some other explanation. So in the lines of the WHO medical eligibility criteria, India also developed this purple wheel, and we were also a part from representing Fogsi when this was done. Dr. Sunita Mittal played a very big role in AIIMS during this development. And we were there with the Ministry of Health discussions which were there, because I was representing Fogsi at that time, taking over from Ritu. And this was one of the discussions which were there when this was being made in India. So it's mainly the WHO wheel with some modifications and some additions of the thing, or from the Indian perspective or the national perspective. So contraception in hypertension, so this is how it used to look, or still looks. So if it is a high blood pressure where a systolic is more than 140 to 160, diastolic is like this, then you have to be cautious in using combined oral contraceptive pills. If it's a patch, or it's a ring, or it's a combined injectable, then also you need to be cautious, because these are the estrogen and progesterone combinations. If it's quite high and uncontrolled, it's an absolute no-no. If it's controlled with medication, then you may think about it. But again, some people in limited circumstances, if it's high blood pressure and persistent high, then you may avoid estrogen containing contraception. Progesterone only, you're much more liberal with that. The POPs, and then is the rest of them. And the IUCDs, of course, seem to be one of the best in this sort of a circumstance. So coming to diabetes a little bit, these are the commonest ones we see. If it is IDDM, insulin dependent and non-insulin dependent, most of them can be, most of the contraception can be used only when it's a long-standing diabetes of more than 20 years. This would be possibly women who have been diabetic at a very young age and need contraception at a very late age. So those people would be there. So more than 20 years means they've started maybe at 10, 12, 15, and then you're talking about contraception later. And then they may also have retinopathy and vascular changes. In that case, it's contraindicated for the estrogen-containing contraceptives, hormonal contraceptives. So with the time and with the change, WHO medical eligibility criteria has evolved, and with the digital technology encroaching into every area of healthcare sector, and this contraception medical eligibility criteria was no different. So now from 29th August 2019, that's the last 2.5 years, WHO has launched an app for its medical eligibility criteria for contraceptive use. So now everybody has a smartphone. India has just 85 crores of smartphone users. And so out of the 140 crores, 85 crores have smartphones in their hand. And this is what the app which needs to be downloaded. And that will give you the same information which we used to depend on the wheel at one point of time. So no hard copies, only soft copies, and multiple ways in trying to get it. So just try to, so this is the, it can be accessed and installed in the Android, also in the Apple, and it gives a fairly comprehensive way of trying to get, trying to find out. So how do you download it? So this is what you need to type in your Play Store, WHO medical eligibility criteria. This is what you get. The dark blue is what you consider, not the light blue. WHO contraceptive tool, you open and then you download it. So how does it look on your screen? It looks like the icon looks something like this. World Health Organization. This is what contraception is. This is the zoom picture of the same thing and still a zoom more picture of the same thing. This is how it looks and this is what you have with you. So what if you click on it, what will you get inside? Well, this is what you will get inside in the beginning. You'll have an eligibility tool, you'll have methods, additional info, how to use the tool, about, and give feedback. So this will be your bullet points on the left side. And this also methods, this is what you will get. You'll get all the different methods which are there for family planning, and you'll have some points on each of them. And the additional info will give you something on emergency contraception, effectiveness of methods, and something on the antiretroviral medications and abrogations. Then then again, so in emergency contraception, if you click there, you'll get the different types of emergency contraception, comparing the effectiveness methods. This is how you'll have pictorial diagrams with the percentages next to it. Very, very user friendly for people who want to find out what are the success rates of each, how effective each method of contraceptive is. You don't need to put your charts. The people often gaze onto their phones for seeing WhatsApp and for seeing other social media posts. So this is something where you get instant information while you're doing this. And the antiretroviral medication section, this is what you get. The NRTIs, the NNRTIs, the protease inhibitors, what exactly is good. So this is the eligibility tool. And so how to use the tool? In the beginning, there's some guidance about what you need to pull in, plug in before you get the results. So there will be, so this is a description of the same. So you will be plugging in. So this is, sorry, and this is the next part of it. So each of these conditions, they will come down when you have the drop box. So they had enormous number of conditions, much more than what we used to cover in the wheel. So you have the age of the patient, which is some criteria which a lot of people think after 40, can I use OCPs, is a very common question. And the very easy answer is yes, you can use it as long as she doesn't have any medical problems. Anticonvulsant therapies, anti-epileptics, various antimicrobial therapy, HIV, living with AIDS, antiretroviral, what all things can be given and in what conditions. These are the various conditions which are outlined there, and we can choose. So once you get into the app, as most of us are very user friendly, handle smartphones very effectively, especially the youth and the younger generation who actually need this most. It is not it's not rocket science for them how to handle this and how to plug in the thing. But for some doctors, some senior doctors like some of us also, we may have some problem in initially getting the idea about how it works, but soon we can look at it fine and understand that how exactly it comes across. Then there is a place for feedback where you can give a direct feedback to WHO depending on how you like it and how it has helped you in your clinical practice. So the carry home messages from this short talk is, remember that the effect of unattended pregnancy in women with medical diseases often outweighs the effect of birth control on the disease. So often when women come with a medical problem, sometimes you think, should I give a contraception? Should I not give a contraception? And you keep on wondering, but not always thinking that if this lady became pregnant, would her risks be more or would her risks be less? And sometimes when we understand that if she became pregnant, her risks would be more than giving her the contraception, then it's better to give it and better to use it. Careful history taking before offering contraception and guidance from the WHO MEC app. And so now it's an app which needs to be taken care of, will help us to deliver optimal care. It's not always easy to remember and memorize everything of all the conditions, but there is help always available, not one arm away. It's in your hand and you just have to use it. And idea is to eliminate ignorance and fear. Thank you very much for your patient hearing. I move on, and if there's some questions, I'll ask.
Thank you, Dr. Basab. It was a great presentation.
Very good.
Well in time.
Thank you.
So can I ask?
Thank you, sir. Yes, sir. Yes, ma'am, I'm here.
Namrata, can you introduce Dr. Muntaha?
Yeah, good. Thank you, sir. Thank you for your presentation. Let's carry the session forward now, ma'am. I invite Dr. Muntaha. I have the pleasure of introducing her today. Ma'am is an MBBS gold medalist and an MS gold medalist, a diploma in urogynecology. A diploma in urogynecology from Delhi, from Germany, and a professor in LHMC, Delhi. She's the nodal officer in charge of family planning. Ma'am has been the ex-co-treasurer of NARCHI and is currently the web editor of NARCHI Delhi. She has various publications and research work to her credit. She will be sharing her experience on ormeloxifene today. We invite you, Dr. Muntaha, for your presentation, ma'am. Thank you.
Hello, can you hear me, ma'am? Hello, can you hear me?
Yes, Muntaha, we can hear you.
Yes, we can hear you.
Thanks for the introduction, ma'am. And a very good evening to all of you. And thanks a lot for giving me this opportunity. And after this wonderful lecture from Dr. Basab, without any further ado, I think I should start my lecture. And so let's discuss about non-hormonal pill, that is ormeloxifene. Can you share?
Sorry to interrupt. Can you make it full screen?
Yeah, ma'am. I'm doing it. Yeah. Now, can you see, ma'am?
Yes, we can see. We can see very well.
Yes.
So let's talk about this non-hormonal pill, ormeloxifene, which is actually a dark horse in a race, according to me, because very less it is used as per its capacity. So in my lecture, in next few minutes, the agenda of my lecture would be the facts and figures, the global and Indian scenario, why there's need to discuss this topic here. Sandchromin has a very good history, and we should know that. And what is the dosage, and what is the mechanism of action? What is the effectiveness, usage, advantage, limitations, side effect of this drug? It is very interesting to know about this drug and what we can do in case of missed pill, and a little bit research work and data which we can do or which is available in the literature. So first let's come to the facts and figures. We have already seen in many slides in a previous discussion that we know that we have the second largest poverty population here. But the good news is the unmet need of family planning declines from 13 to 12%. And until recently, the options were limited. But now we all know that the three things are already been added in the contraceptive basket. And because of that, the MCPR, that is modern contraceptive prevalence rate, it shows linear increase. That is, it was previously 5.9, 1.9, and 4.2%, and study shows linear increase in this by 3 to 4% because of addition of these three figures in the contraceptive basket. So when we see the chronology of the history of the National Family Welfare Program, a lot of work has been done by the stalwarts, and we are getting good results now. And I think this was phenomenal in the 2015. These three things were added: Desantra, Centromane, and progesterone pills, and they have raised a very good opportunity to reach the unmet need. But let's discuss the figure first. What is the current actual situation? When we see the Indian figures, we found that still 46.7% are the non-users of contraceptive methods, and out of the users, it is only 4% which are the people which are using this oral contraceptive pills, which includes the OCPs, POPs, Chaya, and all these. When we see the global scenario, we are lagging behind them. We are only 4%. The all over world is 8%. So, and we can see that all countries like Africa, Asia, European countries, and even America, they are doing good in oral contraceptive pills in comparison to India. So a lot of scope is there to improve ourselves. So now the question comes: why we are discussing all this contraceptive here? Why again and again the family planning people, they are emphasizing that please increase the demand, please increase your efforts, please try your best. So basically, the emphasis is on postpartum family planning with these products because we want to space the birth. We all know that 49.5% according to SRS 2018 births are closely spaced, and we have to space the birth to improve the quality of to reduce the maternal mortality and to reduce the neonatal mortality. And we also want to prevent the unsafe abortions, obviously. And besides this, we want to gain the opportunity also from the high institutional delivery, because at the time of delivery in the institute, we can give contraceptive methods very easily. So we can use this opportunity in conversion of the family planning practices. So but the bad thing in the last 2 years, we all know about this COVID thing that made the world upside down. And that happens to the family planning also. There was decline in contraceptive usage. There was increased demand for abortion services. And according to this FRHS India figure, almost 2.56 crore people, they were unable to access the contraception at the time. So we are struggling with this data also. And so there's a lot of work needs to be done. And with this COVID, because we have to live with this and we have to improve a lot. And we have to again rise from hibernation. So and a lot of efforts are going on, like this webinar itself is an example for this. So let's talk about the Centromane, which have several names. You know, you have heard the name of Centromane, you heard the name of Chaya, it comes with the name of Saheli also. So they all are the same, they all are the name of the different name of the same compound. And this is a non-steroidal, non-hormonal pill, which containing 30 milligram of Centromane, which is a generic name. It is available in the public sector as a Chaya. Nowadays, it is freely available with the name of Chaya. So WHO has approved amloxifene as the international non-proprietary name for the product of this, and which is popularly known as the once-a-week oral non-steroidal contraception, which was previously available with the brand name of Saheli. Oh, as I previously told, it has a beautiful history because we, the Indians, invented this, and it was synthesized by the Central Drug Research Institute in 1967 in Lucknow, and later on it was evaluated And in 2013, it was used as a postcoital contraception, but still the research is going on over this. And now in 2016, it was introduced as weekly once a week contraception as a national family planning program. And after this, now comes to the dosing schedule of the Centromin. So it is once a week pill, as the known itself tells. It is one tablet, that is 30 milligram, twice a week on fixed days for 3 months. We have to give first. And if one takes the first pill on a Sunday, if one takes the first pill on Sunday, she should take the second pill on Wednesday. And from the 4th month onwards, only one tablet once a week. So very less amount of drug we needs to take. We needs to give, or we needs to take. So this is a beauty of this product in comparison to POPs, in comparison to OC, the oral combined contraceptive pills. It is very less amount which we need to take. This is the client motivation point. And the Centromin can be started anytime. It is reasonable, sir. If we are reasonably certain that the woman is not pregnant. If she is starting within 5 days after the start of the monthly bleeding, there's no need for a backup method. So this chart we can give to the client, the lady, which comes to us for the family planning method, and which here we can explain her that how can she take pills in the first 3 months, and then later after 3 months. So now the question comes. This is the dosing schedule. This is the name of the. And now that we have already discussed the dosing schedule, and now the question comes: how this Centromin works, and how can it be different from the other contraceptive pills? The name itself suggests it is non-steroidal, non-hormonal drug. What is the meaning of that? Actually, it is a SERM, SERM. It acts like a selective estrogen receptor modulator with anti-estrogenic effects on uterus. So it has some affinity with some it has some friends, some enemies. So it creates asynchrony between developing zygotes and endometrium maturation, which prevents the implantation of the zygote. So basically, it has local action. It acts on endometrium. It doesn't act on hypothalamus pituitary ovarian axis. It has weak estrogenic action on bones, but strong anti-estrogenic action on uterus and breast. So it favors the bone formation, but on the other side, it prevents the uterine carcinomas and breast carcinomas. So that's the beauty of this product. And it is safe for breastfeeding mothers soon after the childbirth. Immediate postpartum period, we can prescribe it from very next day, which we can't give, except POPs, we can't give this facility in other pills. So now come to the effectiveness of this method. Contraceptive effectiveness with perfect use is 1 to 2 pregnancy per 100 women. But sadly, there's no document failure rate with the typical use is still available. So this is the research field which we can do a lot of work in this. So now come to the who can use this Centromin, whom we can prescribe, or who can use this. So women who want an effective reversible method, there we can give this pill. Women who want OCPs, oral pills, but do not want hormonal pills. A lot of taboos are there, we all know. And breastfeeding women, they can start soon after delivery. Women of any age, including adolescents and women over 40 years of age, we do not need to think कि कहीं उसमें problem तो नहीं कर देगा. Can it cause cancer? Can I give it in hypertensive? It's not like that. And women which having anemia, because it reduces the menstrual blood also, so it can give an anemia also. And women just after abortion, miscarriage, or ectopic pregnancy, we can give this. Even an HIV positive woman, whether or not they are on ARV, we can give this drug. That's a good thing. And who should not use this drug? Where should we cautious? So women with PCOD, polycystic ovarian disease, cervical hyperplasia, any recent history of clinical evidence of jaundice or liver disease because it is metabolized there, severe allergic states, any chronic illness such as tuberculosis, renal disease, etc. In this, we can use this drug with caution, or with this is contraindication actually. And advantages of this drug over the other thing is it is an effective non-steroidal non-hormonal method. Immediate return of fertility on discontinuation in comparison to, we all know Antara, which is there's a 12 to 18 month delay in the return of fertility. It can be used safely by lactating mother. It makes the period lighter, free from side effects, doesn't interfere with sexual intercourse, and like an ICD or like a condom, can be started without a pelvic examination. It has no effect on platelet aggregation, lipid profile, and HDL cholesterol, unlike the OCPs and all. No teratogenic effect, and effective in managing dysfunctional uterine bleeding also. And what are the limitations? But it requires regular, dependable supply, and it did not protect against STDs and HIV-like barrier. And women has to remember the schedule of pill intake. That means twice a week for first 3 months. So they have to remember they have to take on the calendar, and then once weekly. So missing pills can increase the risk of pregnancy. Otherwise, it is very good. The side effect is prolongation of menstruation cycle is the only side effect. That's why it is not given in the PCOS actually. There's a little bit cases of prolongation of menstrual cycle is reported, and it occurs in 8% of cases in the first 3 months. After 3 months, once the hormone level is normalized in the body, then this side effect is always usually gone. So we can explain the client or the lady that after 3 months the period may be normal later on, so doesn't need to worry for that. Then management of the missed pill, like OCPs and POPs, if we miss this pill, so we have to remember that if one pill is missed, then women should take the missed pill as soon as she remember it. If pill is missed by less than 7 days, then women should take the missed pill as soon as possible and normal schedule to be continued. And a backup method like condom to be used till the next period starts. So 7 days is the margin. If pill is missed by more than 7 days, then women should start taking the pill as a new user, means twice a week for the first 3 months, and then once a week. So 7 days is the main period. You have to explain the lady that 7 days is the margin. If you are forgetting it within 1 day, within 7 days, yes, you can take the normal pill, and then please use some additional method. If more than 7 days, then they should take it as a new start. And if periods are delayed by more than 15 days, then pregnancy needs to be ruled out first. So after reading so many things, where we can read the conclusion that this pill is safe on the uterus, this pill on the safe on the even the new studies are coming out that tell that this omeloxifene nanotherapy can be used for cervical cancer also. There's a lot of research going on over this. So when we can see that it is safe on the uterus, it is safe on the ovary, it is safe on the breast, it is safe on cervix even, and it is safe for the bones also, bones health also. Then why we are hesitating in prescribing this pill? These are the very nice pill. We can prescribe them and we can get good result. And if still we are having some hesitation, we can go to the we can Google the things. We can go to the literature, and we find that I found that in British Medical Journal that when I Google it, and I found this very beautiful systemic review. A lot of studies was there. There are a lot of clinical trials over the Saint-Clomin was there, and they concluded that the effectiveness of this in all these trials were around 93 to, you can see here it is around between 93 to 95.9, and even the 100 even in 97 98.4%, and with the Pearl index of 1 to 4. So it is quite effective. And when we see the market research, post-market research client survey, it has good satisfaction level also in 1 to 10 scale. It is around 8. So regarding effectiveness, side effect, and other side effect, consumption pattern, and packaging, if we see. So it has good rapport in market research also, in market research field also. So what are the strategies we can adopt, or we can opt to increase the contraceptive usage of this pill, or any method? First of all, we should do capacity building of providers. How can we do capacity building of providers? By the training, of course, like you are organizing a webinar here, and by the brainstorming, by the research, we can further do capacity building. And another thing, by this we can increase the contraceptive usage or uninterrupted and regular supply of any drug. Like if we want to if we want to get the good result, we have to make the resources available. And the other thing is the extensive involvement of the on-site and off-site staff resources, basically for information sharing and demand generation is must. And complete and easily understandable information to client individual counseling is very much essential, and that the jitna bolenge utna अच्छे results we get, jitna समझाएंगे सामने वाले को उतने अच्छे results we can get. So this is the we should make a good rapport with our client, with the lady, and we can explain her beautifully. We can explain how with the all the facts and figures, and the follow-up is must. And regarding this capacity building, we are also, I want to share with some data from our institute. That was the LHMC data from the last 4 years. You can see here the effect of COVID over the data, and these are the different spacing methods which were used there. And there was decline in 2019 and 20. The maximum thing which was used was condom, but definitely Chaya and BPICD, they were increasing trend. So, and I took over the charge as a family planning nodal officer in August 2021, and we distributed almost 415 Chaya yet, and Chaya was taken and when till yet I saw one case of failure. So I can though it is very early to say something, but I can see that one case of failure I found with so it is around 0.2% to 4%. I found this in my figures in 7 month period. And we are also doing some, so it is good to do some research project. I can't say that this is 100% safe, but yes, we can evolve ourselves by the research and by doing more projects. And we are doing when this project is in our pipeline, as a study of acceptance, discontinuation rate, and side effect profile of amloxifene in women accepting in under Chaya program. And this is the performer. So I invite you all people also that you can do such type of project in your institute, in your center, and you can also help the government of India to you can also help the government of India by your research and by reaching the conclusion that how much is how much is effective is the method. So this is all about the amloxifene. And sorry, by mistake I escaped from my slides. And so last but not the least, thank you for listening very patiently my talk. I hope I would have conveyed some good points here.
Thank you, Dr. Muntaha. That was a very comprehensive description of amloxifene, and I'm sure we'll all benefit by this homegrown medication. Thank you very much, Dr. Muntaha.
Thank you, ma'am.
Can we take the session forward now, ma'am?
Yes, I think. Yeah, better.
Can Dr. Kusumo, Dr. Namrata introduce Dr. Riju? Vikas, CV of Dr. Riju.
May I, ma'am?
Dr.
Sure.
Praveksha can introduce. We can see her.
Yeah. Okay.
Priyanka, please go ahead. Dr. Priyanka.
Yeah.
Yeah.
Hello.
Priyanka, we can hear you.
Yeah. Good evening. Now it is a pleasure to introduce Dr. Ritu. Dr. Ritu Angik Chimote. She is from, she has done her MD Obs Gynae and then diploma in Obs Gynae ultrasound from Croatia. She is a fertility specialist at Vasundhara Fertility Center, Nagpur. And we can see that she's the recipient of Superwoman of Nagpur Award. This is something very good for excellence in women healthcare. And that is what we need. We are not just obs gynecologists. We need to work hard for women healthcare. So please, ma'am, the stage is all yours.
Thank you so much, Priyanka, ma'am. So a very good evening to all. At the outset, I would like to extend my warm greetings as a Sankalp member on behalf of Fogsi Family Welfare Committee. And I would like to thank Dr. Shobha Guri ma'am and the UP OBGY Society for having me here. So my talk is basically a keynote take-home messages of all the talks. So first of all, I would like to congratulate all the speakers, Dr. Ritu ma'am, Dr. Basap sir, Dr. Muntaha ma'am for their excellent talk. So I am basically talking about the clinical pearls, the take-home message. So the world is your oyster and it's up to you to find the pearls. And here I am giving you all the clinical pearls. So the mirage of perfect use, why are we talking about the efficacy rate, the failure rate? Because we know the perfect use, we assume that a contraceptive method which should be used exactly as directed But what patient typically use on the other hand is, is the typical use which represents what people actually do, and it includes all the obstacles to adherence to that occur in everyday life. So that is why proper counseling, history taking is very important at each and every step, at each and every point whenever a woman walks into your clinic. And there comes the importance of Foxi Eye Care Clinic as well. So coming to the first clinical pearl, like Dr. Ritu ma'am very beautifully explained about the progesterone only pill. So earlier when levonorgestrel was there, that time the missed pill period, the woman had to take the pill at the same time every day. And if she missed the pill more than 3 hours, there were chances of failure. But after the newer progesterones have come, like desogestrel and drospirenone, the missed pill period has increased. And the added advantage of drospirenone is that you have a pill-free period as well. And like ma'am explained regarding why that pill-free period is more physiological, because it helps in maintaining the estradiol concentration and the early follicular phase. So in COCs and POPs, even with the low dose pills, low dose COCs, some women do complain of nausea. So we have to take proper history when she comes for follow-up, if at all, if she's having vomiting from the pills or not. And if the vomiting is less than 3 hours, we have to consider it as missed pill. And patients who miss or vomit more than pill should take the new pill as soon as possible and take the next day's pill at the usual time. So those who still experience nausea, first of all, pregnancy should be ruled out. We should change the timing. The pill should be taken with a meal or at the bedtime. Maybe you can add an antiemetic prior to ingestion and switch to a lower dose estrogen dose, or switch to a progesterone only pill. But if the nausea still extends, you can change into a alternative contraceptive methods. So the next is follow-up necessary after starting OC pills? According to the CDC, the follow-up is not necessary after initiating. But yes, in high-risk cases in patients who have comorbidities, medical disorders, it is better to call the patients for follow-up. Careful history taking. Like Dr. Basab very rightly he explained, like women have fear of taking contraceptive hormonal pills, especially POPs and COCs, if they have medical illnesses like hypertension and diabetes. He has beautifully explained about the medical eligibility criteria. If there is no complications, you can safely take the COCs and POPs. And even I have the same slide regarding the app for the WHO MEC. So if at all patients still have the fear, you can always tell about the app. It is very easy to explain to them because everybody is gadget friendly. They always Google. It is better to explain. See, it is not contraindicated. It is safe to use, even though you are hypertensive or diabetic. You can use COCs or POPs. So next is COC should not be given even if a woman is not breastfeeding. COC should not be given in the first 3 weeks. As we know, as we've seen in the MEC, why? Because it increases the risk of venous thrombosis. So COCs, the patients who are on combined oral contraceptive pills can switch to POP or centromone anytime they want, if she chooses to, after being properly counseled about it. The other method, any other method, can be started immediately if she has been using the COCs correctly and consistently. That is very important. Or if it is otherwise reasonably certain that she's not pregnant. So there's no need to wait for her next menstrual cycle, and there's no need for a backup method. So next point, it has already been covered by Dr. Basab, Dr. Ritu ma'am as well regarding the drug interactions. The COCs and POPs, yes, we need to take a proper history. We need to ask for the patient's medications, whether the patient is on antitubercular medicines, whether the patient is on anti-seizure medicines, or medications like ritonavir, protease inhibitor, because these are liver inducers, which leads to increased metabolism and decreased bioavailability of the contraceptive. So in the previous talk, Dr. Mintaha emphasized regarding the dosage that it should be taken twice a week for initial 3 months and then once a week. So why not take once a week for initial 3 months as well? No, it has to be taken twice a week for initial 3 months. Why? Because following initiation of centromone, bioavailability of the drug in the body takes few weeks for its full contraceptive efficacy, and possibly due to inadequate circulating levels of the drug before attaining a steady state. And the studies have shown that administration twice a week in the initial 12 weeks helps to develop adequate circulating levels of drug in the body, and which can then be maintained with a low dose. So after 3 months, you can start with once a week. So next, a backup method, if the a backup method has to be taken till her next menstrual cycle if a woman misses her centromone pill by less than 7 days. But if she misses by 7 days or more, she needs to restart the regime. As in, she needs to again start taking from day one, like twice a week for first 3 months and then once a week for subsequent 3 months. Next point, centromone, yes, it is very safe medicine. Like in the last slide, Dr. Muntaha mentioned that there are papers even on the safety in usage in cervical cancer. It is safe in breastfeeding patients, but still there are few conditions where it should ideally not be given, like PCOS. So women with PCOS have elevated, in women with PCOS, the use of centromone will cause elevated androgen levels, and because of its strong anti-estrogenic action on uterus and breast. And if the woman has a recent history of jaundice or liver disease, cervical hyperplasia, allergic, if she has severe allergic trait, or chronic illness like TB or renal disease, in such cases, it should be avoided. So there are non-contraceptive benefits of hormonal contraceptives as well. It can be used for HRT. It has been used for menstrual disorders. It imparts lower risk of malignancies like endometrial cancer, ovarian cancer, colorectal cancer, and osteoporosis. So coming to my last point, when to stop contraception. So it can be continued if there is no contraindication, if the woman is compliant, she's not having any complaint, she is comfortable using that particular mode of contraceptive, she can continue it. And she may safely stop using contraception after menopause. This means 12 months without a period for over age of 50 and 24 months without a period for people under 50. So how do we know that the hormonal contraception users have reached menopause? So those using progesterone only method may continue until age 55, and patients using an estrogen containing method may continue use until age of 40 to 55 depending on their cardiovascular risk factors, and if needed they can switch to POPs or non-hormonal methods until the age of 55. Thank you so much.
Yeah, can stop sharing. Can stop sharing. That was a wonderful summarization, Riju.
Thank you.
So yeah. So now I think we are open to discussion and questions. Since we did start 10 minutes late, we do have some time, and I asked the experts to give their views. I hope that at least some of them are there. Is Dr. Jyoti there? Dr. Jyoti Sachdeva? Can't see Dr. Jyoti Sachdeva right now. Has she left the meeting?
Ma'am, Dr. Jyoti is, yeah, she's there, ma'am. She is
Okay.
there.
Okay, Dr. Jyoti Sachdeva, do you want to say anything about the centromen? I just wanted to bring to everyone's notice. Yes, sorry, I'll put on my video. Yeah, so I wanted to connect to everybody now. There are about 93 participants still there. Thank you for being there so far. I came to know that the use of Chaya during the pandemic saw the maximum uptake. It saw that is what we were told by the government of India. I heard Dr. Sigdar saying that in one of his presentations. So it is great that availability of chaya did not come down during the pandemic, because we came to know that the availability of IUCDs and other contraceptives came down. So do you want to add anything, Dr. Jyoti?
Yes, actually, this was a boon to us during the pandemic. And fortunately, we had introduced this pre-pandemic, and we also had introduced into the bag of the ashas. So that was one way that we could reach out to women who could not, naturally the MPA and anything which was provider dependent had to go down. Sterilization, MPA, IUCD, and restricted mobility led to the lesser use of that. So maybe the gap was filled by chaya, and since some women were already on chaya, and we could provide that through the ashas who actually were moving for more apparently essential things like anti-hypertensives and anti-diabetics to elderly people. But since they had it in their bags and they didn't have to move, especially for these things, they could cater to this need of women during the pandemic. So it was one thing that we were fortunate to have it already pre-pandemic. The other thing is that this is being non-hormonal, it is perceived as more safe than Malayan. And with tele prescriptions and with tele consultations and tele counseling, this was somehow the simplest thing to allow, because screening does not really require a lot of physical examination or physical this thing. So this was one thing that we could allow through ashas, and it showed in the statistics that you just mentioned, what Dr. Sigdar was saying. And we are also anticipating a higher usage of this, and we are working towards increasing the continuation rate of these. And of course, there are women who do not want to take pills daily, and who are very averse to the idea of ingesting hormones. So there these things come into play, and of course the lactating women.
I think that is those are all acceptable, arguments in favor of Centroman. However, there is only one thing which has troubled me about Centroman so far, and that is the lack of literature or the lack of research on the product, and the lack of mention of Centroman in the WHO MEC criteria. Okay, so it's so far not included. So we should be looking forward to this. Now, I do not know exactly how that will come about. It may be question not meant for this webinar level. So we shall not go more into that. I think that only time will tell. We can move forward and speak about other things which were discussed today. One question was on drosperinon. Whether it is available. Yes, it is available. Sun Pharma is marketing it. So usually it is against the principles of to talk about any brand names. But since there was a direct question, there are actually 2-3 companies, but the one which launched it first was Sun, and it is Sun Spectra actually, to be exact. It is Dronis P 4 milligram, 24 tablets per month, and the cost may be around 400 rupees or so. I'm not very sure, but I will soon make it sure and post it on the group. I have asked for confirmation. So I have prescribed it a couple of times, and there's before I open the uh, to others also to contribute. There's only one thing which I want to speak about POP, and it's a strong message I want to give to everyone that POPs are proved by evidence to be very good, useful in 2 situations where there is a break in regular contraception. One is as a bridging method, okay, and one is for a quick start. Please remember these 2 things are different. A bridging method when there is a change from one to another, or there is a emergency contraception which is taken and the woman wants to adopt the next method after her period. For example, she may want an IUCD insertion later, but she might have taken a EC now. So it's a very good bridging method till then. The other one is a quick start, because I think this was told by Dr. Ritu Joshi also. So it's an excellent quick start method. It can be given any time of the cycle, provided we are reasonably sure that the woman is not pregnant. So POP has this wonderful asset, and it is very underutilized in our community. Even worldwide it is underutilized, but I think it's a very special place in the basket of choice. Yes, it should encourage us. All this story about POP should encourage us to prescribe it more. Yes. Yeah, Dr. Jyoti Bajpayee.
Yeah, so I had a comment. So we were talking about Centroman not being there, not being recognized internationally or even by WHO. It is our national pride that we've developed this, it's an indigenous contraceptive. And we, in a country with so much population, I think we can do good research and make it, available for the world to read. I was in a high-level meeting at an international forum where we were talking about Centroman, and the biggest objection was that there are not enough RCTs or not enough research to prove that it is effective and, to say it is effective and not harmful. So I think we need to do that as a nation, because this is what we've developed. We have to have pride in it, and we have enough, now with the increasing popularity, we may have enough, people using it to do the research. So I fully agree that we need research on that. The other comment that I want to make is now with the focus on the young low parity couples and a paradigm shift from, looking at women in the later phase of their life going in for sterilization as a method. But, that focus on spacing and focusing on adolescents and newlyweds and the youth. We need to be, as practitioners, we need to be very clear on the spacing methods and their advantages. And you spoke about bridging and transition. So all methods that can be used to bridge from one contraceptive method to another is also very important. Because let us remember that the earlier the youth start experimenting with contraceptives, the first contraceptive method may not suit them. So they will probably discontinue and want to go to another method. So the bridging methods also need to be understood, and what we can offer the young and the youth and the adolescents in this country. If we keep our focus on them, I think we will very, very soon be, the momentum will be maintained and the trajectory will be high. Thank you.
I could just now get the price of Dronis P, and it is 480 rupees.
Yeah.
And I think it is a good investment for a woman to put aside for contraception per month. It is nothing much. It costs less than the cosmetic products which many of our women use. So it is all right to spend on contraception. Yeah.
Not much.
Thing about drosperinon which we could gather is that ma'am said that it doesn't cause estrogen deficiency as compared to other POPs. So these are very good. I would think it would be a very good choice. It reduces high blood pressure also, and lot many perimenopausal problems can be catered to. And I think that would be a good pill if tried in the 40s, I think 38, 39, 40 years.
I have one question from Dr. Muntaha. Dr. Muntaha, are you there? Yeah, she's there.
Yes, ma'am. Yes.
You shared your data about the use of non-hormonal contraceptive, which is very good. It's increasing also. I just wanted to know what was the most challenging side effect. As we all know that secondary amenorrhea is the most challenging one. Actually, sometimes we we even in our presentations we have heard that women take it positively as well. So what actually is the reality? What was the most challenging thing which is responsible for any discontinuation, if you have observed or you have any data on that?
What we are observing, ma'am,
Yeah.
That patient follow-up is actually the problem. When we call them, maximum of them they are lost to follow-up, and sometimes they are in the village and they do not find this thing there, and but the thing in the last meeting with the Dr. Jyoti ma'am also we were discussing, and what are the things which we can do to further improve our follow-up for these patients. And the patient actually the clients they do not know much about this drug. They know about combined pills, they know about the progesterone pills, but they do not know much about. They know some of them they know the Saheli very well, but uh, with the proper instructions, with the proper follow up, definitely we can improve the data. And we are insisting mainly we have targeted now the postpartum patients in our institute, and we are trying to give them as much as possible postpartum and post-abortal patient, and we are finding very good results in them. Otherwise, in interval patient, yes, it is difficult to motivate them to take them again to the institute. So I think the postpartum is the very
I think client tracking is the problem. We need to do something for client tracking.
Yes,
and
ma'am.
of course the literature, as Dr. Shobha said. Thank you so much.
Thank you.
So I think
it is good to conclude on this note, on a winning note, when everybody has spoken well and we have given clear messages today. So we look forward to more such gatherings. Thank you, PSI.
Thank you so much. Thank you,
Thank you,
Devanshi. Now I would like to
Thank you.
invite Dr.
Thank you,
Namrata.
everybody.
Dr. Namrata
Thank you, Dr.
to say the vote of thanks.
Yes, ma'am. Thank you.
And Dr.
Thank you for giving
Sangeeta also to final vote of thanks and concluding remarks.
First of all, thank you, ma'am, for inviting me. And thank you so much to our Foxy stalwarts, Shanta Kumari, ma'am, Dr. Machi Patel, ma'am, and Dr. Vasav Mukherjee, sir, for blessing this webinar of ours. Chandravati, madam, for blessing us and giving your Ashirwad. It is always needed, ma'am. Dr. Shobha, what can I say about you, ma'am? You are the guiding light of this webinar, the guiding light of as the chairman of FWC, ma'am. Thank you so much for gathering us around you and learning from you. Our experts, Dr. Jyoti Vajpayee and Dr. Jyoti Sachdeva, thank you both of you, ma'am, for sharing your pearls of wisdom with us. I would like to thank my chairperson, Dr. Manju Gupta, ma'am, President Muzaffarnagar Society, Dr. Kusum Verma, ma'am, President Mau Society, and Dr. Priyanka Gar, my dear friend, Secretary from Meerut. And our speakers, the more I say about them, I just cannot match their expertise. Ritu Joshi, ma'am, for her insights on POP. Shobha, ma'am, for your integrated services. Basav, sir, on combined oral contraceptive pills and that app. I think it is going to benefit all of us. Dr. Muntaha for highlighting the effects of hormonal oxygen, and Dr. Riju for your clinical pearls. Last but not the least, our convener, Dr. Shikha Srivastav, and coordinator, Dr. Sangeeta, ma'am, thank you so much for making me part of the webinar, and thank you all for attending it. Thank you.
Thank you, Namrata. In the end, I will just like to thank the PSI team, our ED, PSI Mukesh Sharma, Chief of Party Hitesh Sani, Deputy COP Samren Behra for their support for this event. I owe special gratitude to our IT team, Mr. Bhaskar Belwal, Vikas Gupta, Sujit and Zafir, and all good hearts who worked hard behind the screen. Last but not the least, I thank our district teams in 25 districts of UP who had worked hard to see that knowledge shared here reaches the last mile and to ensure that this event becomes a memorable success. We had a participation of 145 participants. Looking forward to many more such webinars in states of UP, Bihar, and Jharkhand. Thank you, everyone.